Welcome to the Fibromyalgia Podcast. I'm Tammy Stackelhouse, fibromyalgia coach, author, and founder of the International Fibromyalgia Coaching Institute. The goal of this podcast is to empower you with access to the dream team of experts and coaches I've discovered are key to living the fibro life you love. From the comfort of your own home, and maybe even your pajamas, I'll help you take back control of your life and health. To help out with fibro fog, I always include full show notes and additional resources at fibromyalgiapodcast.com. Welcome to the Fibromyalgia Podcast. I'm your coach, Tammy Stackelhouse, and this is episode 182. Today, we're talking about one of the most frustrating symptoms many of us with fibromyalgia will deal with: insomnia. Not just trouble falling asleep once in a while, but the kind of sleep disruption where your body feels tired, your brain just won't shut off, and night after night, you're wondering why sleep just isn't happening. And that is the worst. Today, to help us understand what's going on, and more importantly, what actually helps to improve it, I am joined once again by Dr. Leon Lack. Dr. Lack is a sleep researcher and professor emeritus at Flinders University in Australia. He has spent decades studying circadian rhythms and insomnia, and his research has helped shape many of the behavioral treatments used for insomnia today. You may remember him from one of my favorite interviews over the last year, episode 173, Fibromyalgia, Sleep, and Your Body Clock. In today's conversation, we are going to go deeper into insomnia specifically, what causes it, why it can be so persistent, and what you can do to start retraining your sleep. Before we begin, I want to share a quick note about today's conversation. In this interview, you'll hear Dr. Lack explain how chronic insomnia develops and how cognitive behavioral therapy works for insomnia. This is also called CBTI. Some parts of CBTI can be really challenging for anyone, but especially if your fibromyalgia symptoms are closely tied to your sleep. In this episode, we want you to understand how insomnia works and give you some strategies, but you need to talk with your providers on what actually fit your body and your situation and your fibromyalgia body. As always, I do want to remind you that the information included in this podcast should never be considered medical advice, nor is it intended to replace consulting with a qualified physician or other healthcare provider. Our goal here today, like I said, is to just give you some new ideas and some things you can take to your providers to see if they're right for you. We'll also have links to everything we talk about today in our show notes. Just go to fibromyalgiapodcast.com/182 for today's episode, where you will find links to my previous interview with Dr. Lack, other episodes related to sleep, and more. In fact, Dr. Lack is going to mention in this interview a place where you can find CBTI practitioners. That link will be in today's show notes as well. Now, here is my conversation with Dr. Leon Lack. Welcome to the show. It's good to have you back.
It's good to see you again, Tammy.
Let's start with the basics. What is insomnia?
Well, insomnia is a fairly generic term. It usually refers to people having difficulty with their sleep. And what do we mean by difficulty? There are different aspects of the difficulty. People can have a problem falling asleep initially when they go to bed, and they want to get to bed by 11 o'clock because they know they have to wake up at 6:30 or something in the morning. And in order to get enough sleep to satisfy their sleep need, they have to get to sleep by 11. All right, so they head towards bed and try to do all the right things. Don't sit in front of a screen for the hour before going to bed, and all these sleep hygiene sorts of rules, some of which are sensible and reasonable, but Others don't really have very strong evidence to support them. So they might sound logical, but really have very little impact on people's sleep. For example, exercising before bedtime. Say, oh, don't do that because that'll excite you. And you want to wind down before sleep. But the evidence doesn't really support that very strongly. You can go out, if you, the only chance you have to go to the gym is between 7 and 8 o'clock at night. It'd be better to go to the gym and exercise and be reassured that's really going to have very little impact on your sleep that night. It might be a positive impact. Okay, so a person goes to bed at 11 o'clock, they turn the lights out, get comfortable in bed, and then nothing. They're still awake. They might look at the clock and now it's 15 minutes later, they're still awake, and they're not really feeling very sleepy. And this can go on for a long period of time. It can take, maybe half an hour, maybe an hour before they finally fall asleep. But inevitably, their brain is still active and they still think. And what are they thinking about? Well, they're thinking about, gee, it's been 45 minutes, I'm still awake. This means I'm only going to get 6.5 hours of sleep before I have to wake up to the alarm clock in the morning. And that is a source of anxiety, and that can keep them awake even longer. So they're faced with a threat. And when we're faced with a threat, what does that do to our bodies? It triggers off the fight or flight reaction automatically if you perceive a threat. And as time goes on and you're still awake, the threat gets stronger. So the body's fight or flight mechanism, adrenaline secreted into the bloodstream, your heart rate increases, blood gets redirected to the muscles in the brain because the body's now ready for action. That's not conducive for falling asleep. So they can get themselves into this vicious cycle of worrying about sleep. And if this happens night after night after night, or maybe 3 or 4 nights a week, that can become a habit pattern such that just going to bed and wanting to fall asleep at 11 o'clock at night becomes the cue to trigger off that fight or flight mechanism automatically.
Yes, I have had clients like that where it's almost like they have almost a PTSD response to sleep, like just thinking about sleep makes them unable to sleep.
Yeah. And we call it in psychology a conditioned arousal response. And it's just like Pavlov's dogs. I don't know if you know that conditioning. But Pavlov's dogs, a bell would ring and they'd be perfectly happy. They'd be measuring saliva output. But a bell ringing doesn't produce saliva unless you ring a bell and then you put food acid in the mouth, and that causes the salivation. And then if you do it again, ring the bell, food acid, salivation, ring the bell, food acid, salivation. Pretty soon, after many, many trials of this, you just ring the bell and salivation will then take place. We call that a conditioned response. It's a very primitive form of learning, and we all have it. Dogs, cats, earthworms, humans show that type of primitive learning. And that's the type of learning process that probably takes place in this conditioned arousal response to going to bed. So initially, the bedroom environment doesn't have any power to elicit alertness unless we experience this threat night after night. And then the bedroom and even the attempt to sleep, the idea, I want to go to sleep now, becomes part of the trigger as well to trigger off this automatic arousal response. Yeah, I have had lots of patients that have said they'll go to bed and they start feeling sleepy. They're struggling to stay awake in front of the television set. They think, oh, I'll catch this wave of sleepiness. I'll go to bed now. And they put themselves into bed. They turn the lights out and they're like this.
Yeah.
That's really a good sign that there's this conditioned arousal response that's taking place in them. And that's the basis of chronic insomnia. People that have had the condition for a long time, they've had a lot of experiences of the association of the bed environment and their attempt to sleep with not being able to sleep and with getting anxious and aroused. So this arousal response is getting in the way, and that has to be treated. All right, so getting to sleep initially is one of the clinical signs of insomnia, but there are other problems with sleep too, particularly as we get into the older population. You don't find that problem so much about initially getting to sleep, but you find the problem of waking up during the night and then not being able to get back to sleep is their big issue. And so people with sleep maintenance insomnia, the difficulty maintaining their sleep. And there are some individuals who don't have any problem falling asleep and don't wake up a lot across the night, but then wake up after only 5 hours of sleep and they wake up, pop, it might be 3 o'clock in the morning, but they still can't go back to sleep again, and they don't get enough sleep. So that's early morning awakening insomnia. So these three different sleep symptoms: difficulty getting to sleep, lots of awakening across the night, or too early in awakening in the morning. Those are the sleep symptoms. But since about 2000, insomnia also has to include some daytime impairments as a result of their disturbed sleep at nighttime. And the type of daytime impairments that are very common in people who have chronic insomnia are fatigue is particularly the biggest one. And your clients are aware of that. Sleepiness, strangely enough, is not very common in people that have chronic insomnia. They tend to be hyper aroused sort of individuals and worried almost all the time about their sleep. And not only worried when they're trying to fall asleep or get back to sleep at night, but thinking about their sleep during the day. And that triggers off the fight or flight reaction too. So it keeps them sort of hyper vigilant. They're like people that are on high levels of caffeine across the day, but they haven't had any caffeine because they know that's also one of the sleep hygiene rules: get rid of caffeine, which they have done
Right.
already. They've done that already, but they still can't sleep. That's because they have this conditioned arousal response, which is keeping them hyper vigilant. Fatigue is their experience, and we don't really know exactly where fatigue comes from, but we can relate that to that fight or flight reaction, which they have during the nighttime, particularly when they're trying to sleep, and also if they have worry about their sleep during the day as well. What that does is trigger off the fight or flight reaction. That's fine, but it was an adaptive response for us in the occasional emergency, and it was to get our bodies out of harm's way. And once we're out of harm's way, we can finally relax and recuperate. And that recuperation period is usually very much longer than the excitable period. And if you've ever been strongly startled by something and really become activated or anything, that lasts for about maybe 10 minutes at the most. And then once it's clear that there's no harm to you any longer, you settle back down again. You then feel a fatigue come on you that might last for hours afterwards. And so the resultant carryover fatigue from this poor fight or flight mechanism being triggered off all the time, we think is the source of the fatigue that comes from chronic insomnia.
So, not so much fatigue because you didn't get enough sleep, but fatigue from the sort of the letdown after the, wow, that's
Yes, that's right.
interesting.
Of course, you do feel fatigue if you don't get enough sleep, so that does contribute to it. But it's coming more from the recovery process that the body's trying to put you into. Some really interesting experiments were done in the United States maybe 30 years ago now, where took a group of participants and woke them up a lot across the night. So they only got, say, 5 or 5.5 hours sleep every night over a whole week. So they simulated an insomnia sleep pattern and restricted their sleep. And the result of that was they just got very sleepy, and they couldn't keep them awake during the night, during the day. And they fell asleep like that at nighttime. They built up a lot of sleep pressure. So restricting sleep itself will just make you sleepy. It won't make you fatigued necessarily. So they didn't capture the types of daytime symptoms that the chronic insomniacs have. So then they took another group of participants, and instead of disrupting their sleep by waking them up, they fed them high levels of caffeine across the day, the equivalent of about 10 cups of coffee, a new cup of coffee every 2 hours across the day. And that disrupted their sleep as well in the same sort of way. But they started experiencing, after 2 or 3 days of this high levels of caffeine experience, fatigue and distress, and they started showing all of the typical symptoms of chronic insomnia. That produced the caffeine model of insomnia. In insomniacs, not due to the caffeine, but due to some hyperarousal that the normal subjects were experiencing with the caffeine. I think that lends itself to this explanation that fatigue is coming mainly from this overexcitability and overarousal and its repercussion during the day. Okay, so fatigue is the main one of the main symptoms. Mild depression. That's hard to know whether or not that's pathological depression. It's certainly there's an overlap between chronic insomnia and people with depression, and they both measure high on depression. But there are a lot of symptoms that are in common between depression and chronic insomnia, and the fatigue is certainly one of them, and lack of motivation. In some chronic insomniacs, that depression can become quite severe and trigger off more severe depression. Not at all surprising, because if you're feeling most every day like you just can't cut up and face the world, you don't have the energy. If you're forced to do things during the day because it's such a high value to you, you can do it. You can get through it, but it feels like it takes a lot more energy to do it. So it doesn't incapacitate you, it just means that your energy levels are not there and you don't feel that spontaneous enthusiasm and ability to just go out and do things without any effort. It takes much more effort. So mild depression, fatigue, distress, feeling anxious about your sleep, and lots of things you see in the media these days about what happens if you have chronic insomnia. Well, all these health risks are increased. And so people get very worried about that. Of course, worry is a mild fight or flight reaction. And so that contributes to it as well. And particularly if you're having trouble getting to sleep or getting back to sleep when you wake up, you start thinking about, oh, yes, all those things you saw in the media, which will exacerbate your worry and concern and intensify the fight or flight reaction, which just is going to make the insomnia condition worse.
Yes, this sounds like an absolute vicious cycle, right? Like the thing that causes the problem makes the problem worse. I want to back up to something that you said a little bit ago. You talked about fatigue and you talked about sleepiness as two separate things. Could you clarify that just a little bit for us?
Yeah, they are different concepts in our language and for most people. And we've actually studied this because we're interested in the difference between fatigue and sleepiness and tiredness. Tiredness is another word that's used. And we subjected people to making judgments about fatigue, tiredness, and sleepiness on a whole range of different scales that was able to sort of identify the connotative aspects of these words, what they mean in terms of good versus bad, active versus passive, and potent versus impotent. Those are sort of the three dimensions in cognitive space that you can plot every word or every concept on. And so we use that methodology to plot the positions in three-dimensional space of these three concepts. Thought this would quantify the differences between them. And indeed, we found a big difference between sleepy over here was not bad. It was a little bit better than fatigue. Fatigue was badder and and more potent. And tiredness was almost exactly in between sleepy and fatigue. And indeed, people use tiredness in different ways. That can refer to being sleepy. Sleepy is sort of seen as a bit of a weak word. You know, if you're sleepy, that's just an indication of weakness.
It's almost neutral, isn't it, too, a little bit? Like everybody gets sleepy every day or
Yeah,
should.
but we can offset sleepiness and we can overcome
Ah,
sleep.
got
But
it.
fatigue, where does fatigue come from? Fatigue comes from hard work, so that's really a prize, but it's also very strong. It's slightly negative because it's not such a good feeling. It really stops us from doing things. So if you're sleepy and you want to feel, I want to say that you're ready for bed. You say you're tired rather than just sleepy. You wouldn't say you're fatigued because fatigue comes from overwork, physical or mental, sticking at one task for a long, long, long time. You get fatigued with that task. So the concepts really in the general population are quite distinct from each other. And that became apparent to me when I was treating people with chronic insomnia. They would rank very low on the sleepiness scale and very high on the fatigue scale, which was, really curious because usually you think generally these things are highly correlated, but not in chronic insomniacs. They differentiate really nicely. So, and then as we started exploring what is the concepts of what are the meanings of these words, and they are quite different, with tired being sort of in between. So you can use tired to mean fatigue or sleepy, and people do.
Right. That's so interesting. And I don't want to get us on too much of a tangent here, but when you were talking about fatigued being associated with hard work and things like that, I wonder if that's why there's so much stigma around chronic illness and people who are fatigued because we haven't done anything.
Oh, that's
a whole nother podcast episode.
you don't deserve to be fatigued because you've been just lying in bed.
Exactly.
Yeah, that's right. That's right. That's really an interesting idea. I must remember that. In our field, I also get irritated at the engineers who deal with public safety and stuff like that. And they equate the term fatigue and sleepy. In fact, we have road signs that says the only way to overcome fatigue while you're driving is to sleep. That's not really true. A driver driving along the highway saying, "Are you fatigued? Pull over and have a sleep." No, I'm not fatigued, but I am falling asleep behind the wheel. This falling asleep on the job, which is really dangerous. But in the engineering fraternity, fatigue is the word that's used to mean sleepy, basically, or the propensity to fall asleep. This irritates me. No way.
So let's get back to insomnia. I see this a lot. The three things that you talked about I see over and over again with clients, right? Having trouble falling asleep, having trouble staying asleep, and then waking up super early and then you're just done. I might as well get up now. I assume they all have different approaches for treatment, or is that a wrong assumption?
We feel that they should have different approaches to treatment because they do represent different underlying causal mechanisms. Not entirely different. If they have chronic insomnia and have had chronic insomnia for a long time, there will be, in my estimation, always this conditioned arousal response process, which is part of it, which needs to be reversed. It needs to be treated and corrected so that that response is no longer taking place. So in other words, a person trying to fall asleep with only a sleep onset problem will have this conditioned arousal response. Or a person who wakes up during the night and lies awake for half an hour or so and starts to get anxious and thinking about things and gets anxious about the fact that they want to get back to sleep and they can't. Again, that response is taking place and contributing to their difficulty getting back to sleep. And also the person who wakes up too early, wakes up, looks at the clock. Oh, damn it. It's 3 o'clock again. I always wake up at 3. Why does this happen to me all the time? So they also will have a conditioned arousal response as well. So that'll be part of it in all cases. And so what we talk about in treatment, non-drug treatment, is cognitive behavior therapy for insomnia. So we deal with people's ideas, their cognitions, their reactions, their psychological reactions, and their behavior, and trying to change the behavior and trying to change what happens to them when they are in bed trying to sleep. So we will detail that a little bit later.
That makes perfect sense. I mean, because if you don't shut that down, it just keeps going. You're just perpetuating the problem. Now, we are going to talk about CBT a little bit, but is there a place for drug treatments with insomnia?
I have a personal opinion which is slightly different than my association.
Okay. Give us both.
Okay. What's said in the manuals is that CBTI is the recommended first-line treatment for chronic insomnia. And there's no doubt about that. The evidence is overwhelming about its effectiveness, and it's more effective than drug treatment. The drug treatments, look at the pharmaceutical companies have had over 70 years to try to perfect the perfect magic bullet for sleep, and they have not at all been successful. They've tried one thing after another, after another, after another, and they all have a small beneficial clinical effect, at least in the short term. But in the long term, they only provide clinical improvement, reducing clinical symptoms a bit, but you take the drug away and the insomnia is back again. So it doesn't treat the underlying conditioned insomnia. It just provides a bit of a Band-Aid for their sleep. So for chronic insomnia, the field is perfectly clear, and I'm in agreement with them. CBTI is the way it should go. The problem with CBTI is, how do you get it? There are some online programs now that are available for the general population, for everybody, but they're not as good, it's generally felt, as a one-on-one or even group therapy by a trained CBTI clinician. I think that's probably correct. So to get really the best treatment from somebody who's really experienced at CBTI is the way to go if you can find one who isn't booked out entirely. There aren't very many people around the world, both in the United States and in Australia. There are a small number of psychologically trained people that know about CBT in general and now have learned how to do CBTI for insomnia and do it very well. But in Australia, we might have at most 200 practitioners for the whole country with 2 or 3 million chronic insomniacs. That's not going to go very
The
far.
math doesn't work.
It doesn't work. And
No.
the same problem by and large exists in the United States as well, and in fact throughout the world. Gradually, and our main aim is to try to train more and more people to be able to treat people with CBTI because it is the best treatment in the long term. And so that's the main practical problem we have with it. So CBTI is recommended, yeah, but how do you get it? Your GP is very unlikely, your general practitioner or medical practitioner. They haven't been trained in this. They don't know about it. Their tools of trade are drugs. And so the first thing that comes to their mind is, which one of these hundreds of different hypnotic drugs do I use? That's their main issue. Which one do I use? Oh, the benzodiazepines. They've had bad press lately. Let's try to find something else. Well, the Z drugs, maybe zolpidem and zopicon. There have been some sort of side effects that are worrying about those too. Other things, maybe melatonin. Let's think about that. That's pretty innocuous, and that has some evidence to support. So melatonin will be safe, but maybe not much better than the placebo effect. But they won't recommend the herbal remedies that you can buy in the health food shops. And rightfully so, because there's almost no evidence to support, no good randomized controlled trials to support any of those things. Placebo effects is what might make them effective for a short period of time. So their tools of trade in the medical profession are drugs, and they haven't been trained in CBTI. We're trying to train up some general practitioners and some practice nurses to do it, and found a few, enthusiastic ones that can do it really well. So you can learn how to do it without too much training and understand how to do it. But it's a matter of getting this training across to you.
So is that then where sometimes there's a place for a Band-Aid?
Oh, okay. Okay. So for chronic insomnia, yeah, CBTI is recommended. But if no one's there to do it, then what else do you do? The medical practitioner is not left with anything except possible choice of different drugs. But in the short term, that is for acute insomnia. And the acute phase in the past has been limited to if you've had those symptoms for only up to a month, but more than a month becomes chronic. And for acute insomnia, it seems reasonable to use a hypnotic drug for, those severe experiences that people might have, loss of a loved one, a loss of a job, and so forth. So those really traumatic events that might happen in your life that naturally cause sleep disturbance. They're a threat to your welfare. And that threat automatically triggers off the fight or flight mechanism because you've got to do something to deal with this threat, basically. So it's an adaptive response that's built into us. But in many aspects of modern life, it's not very helpful. And and so a person may be experiencing insomnia for a couple of weeks because they've had a terrible incident in their workplace, they've been bullied, and they can't quit their job, they can't complain, or something like that, or worse, it can cause sleep disturbance. So they go to their medical practitioner. Then the rules say in acute insomnia cases that hypnotic drugs might be the best solution. And that seems reasonable, doesn't it? Here's a person that's just suffered a bad incident and they're experiencing acute insomnia. It hasn't become conditioned insomnia yet. So hypnotic drugs might be the most reasonable thing to do. And of course, they have a whole list of them. They can say, well, okay, we'll use this. It's not very habit forming. And we're only going to recommend it for a month. It's unlikely that you become addicted to it after just a month or even 2 weeks. And that's even safer. But the acute insomnia has changed its definition more recently to be 3 months.
Oh, wow.
So it enlarges the window in which our field says hypnotic drugs are fine to use for these acute insomnia cases. But after 2 or 3 months of insomnia, I would consider it now chronic and very likely that this conditioned insomnia has developed, which needs to be treated by CBTI. And so the drugs are not going to really impact that. It'll provide some short term beneficial effect, but it'll be a band aid. And once you stop taking it, the insomnia will come back.
It sounds like one of the best uses maybe for them is to hopefully maybe prevent that conditioned response when you have a situation that is maybe triggered, like you were saying, something bad happened at work, you lost a loved one, whatever. We don't want to create that conditioned response that's going to create chronic insomnia. Maybe using medication to help get you through that can perhaps avoid some of that. Or at least that's the idea.
And that fits in perfectly with rationale that the medical practitioner would have in their mind to say, this is perfectly safe. The trouble is that almost all of these hypnotic drugs have tolerance effects to them. So in other words, when they're initially used, they are the strongest and most potent. But gradually over time, their effectiveness tends to diminish. So the benefits you get from it get smaller and smaller and smaller. And then when you stop, and even 2 weeks is enough time for tolerance effects and drug dependence to develop. And so you stop taking them, and the insomnia bounces back. And it might bounce back in more severely than it was prior because of the drug withdrawal. So that's always a problem. And the percentage of people who are initially prescribed a hypnotic drug for acute insomnia, the percentage who go on are still using it after a year, who become more permanent drug users, is something in the order of, from I recall, about 20%. So there's always a certain percentage of people, even though you use it for just acute insomnia for a brief traumatic event, will go on to become drug dependent and have a lot of difficulty getting off of the use of the drug because they say, gee, doc, I can't sleep without the drug. Yeah, because you're in drug withdrawal, basically, and you have insomnia rebound. These days, the drug companies are a bit more subtle and clever about their recommendations. They realize that the hypnotic drugs, there's some concern about them, and mainly the tolerance and drug dependence effects. And so what they recommend these days, no, in fact, the drug reps go to the doctors and they say, look, if you're unhappy about prescribing this drug every night, then use it as needed. And so the person ends up using it 2 or 3 or 4 times a week rather than 7 days a week. And that helps to satisfy the medical practitioner. Oh, okay, that's a good idea because then they'll maintain their drug sensitivity and tolerance won't build up. They won't have an insomnia rebound. But the major problem with that is psychological dependence, because what ends up happening is that the patient also might be a little bit concerned about using the drug every night. So they don't. So they use it one night to get a good sleep, feel refreshed the next day. But the next night saying, oh, I won't use it tonight. This is my day off. And they don't use it. And their sleep is not nearly as good. And they feel a bit washed out, a bit rotten the next day. And they'll say, well, I'll extend it for another night. I can do this. I'll go 2 nights without the drug. And they do, but the second night isn't any better. So they have now 2 nights of poor sleep and reduced sleep time. They have a buildup of sleep pressure. And so the third night is likely to be recovery night, good sleep anyway. But that's the third night they take the drug. And the drug has sort of recovered its sensitivity a little bit. So it's a little bit more potent, but they have a lot of sleep pressure going for them. And they take the drug that night, they get a great sleep, and they feel great the next day.
Which
But then
just
the next night,
reinforced the idea.
yeah, exactly. And so they flip back and forth. They have this huge contrast effect between the nights they take the drug, they get a great sleep, and they feel good the next day. And nights they don't take the drug, they get poor sleep and feel rotten the next day. So that real contrast effect, the drug, great, no drug, ugh. And so this goes on for a long time. And the contrast effect between those two things weds them to that drug. They know they still will be able to use it. And the placebo effect of the drug becomes really great too, because they know that consistently, if they use the drug on the night after 2 nights of not using the drug, they'll get a great sleep. And so this PRN, use as needed technique, is wonderful for the drug companies because even though they don't sell as much drug over the short term, they have somebody who will take that drug the rest of their life because you'll have great difficulty weaning them off of it.
Yes, yes. And I think this brings up one of the concepts that I really wanted to get across to you listening, and that is sleep is complicated. There are biological things that are going on, but there are also psychological things going on. And so we can't address sleep without looking at the whole picture. It's not just as simple as taking a medication or as simple as not taking a medication, I think.
Yeah, you're right. But people just have a problem. They have a difficulty and they want a quick solution. And
Absolutely.
they want it to be simple. But with chronic insomnia, they have a habit response that's built up over time, not to their liking. They didn't want it to happen. It just happened because of circumstances. If we change the circumstances, that condition insomnia will diminish. We call it in psychology extinction of that conditioned response. It gets weaker and weaker and weaker so that it no longer has the power to trigger off that arousal response. Okay, different types of sleep symptoms. And to emphasize your point about there being differences between different types of insomnia, we've identified that as well and feel that people who have mainly just a problem getting off to sleep initially, in fact, we've done research to prove this, is that they also are likely to have a body clock, which is delayed. And they are trying to fall asleep at an alert zone in their body clock, and which is inhibiting their ability to get to sleep. And so that is a factor that's contributing to that sleep onset insomnia problem.
And for that, we refer you to episode 173
That's right.
Fibromyalgia, Sleep, and Your Body Clock.
That's right. Because there's a body clock involvement in that type of sleep. And so morning bright light can be helpful at shifting the body clock back earlier, as well as the cognitive behavior therapy for insomnia. So combinations of treatment are used for combinations of factors that are contributing to the insomnia. Likewise, people who have that early morning awakening insomnia, who fall asleep easily, particularly who are getting tired very early in the evening, fall asleep within minutes, and then wake up at early in the morning, 2, 3, 4 o'clock in the morning, and they have another 3 hours before they have to get up, but they are fully awake and can't get back to sleep, are shortchanged on their sleep. Well, those people we have shown in our studies to have a circadian rhythm or body clock that's timed too early. So their alert zone is very far back in the afternoon, and their awake zone is in the early morning at 3 or 4 o'clock in the morning. Whereas most people's awake zone is about 7 or 8 a.m. in the morning. Their awake zone is occurring early and is contributing to their difficulty getting back to sleep. So if we can delay their body clock by using the evening bright light, we can help to treat that type of insomnia as well.
Ah, yes, that's such a factor.
The main treatment, CBTI, we need to get back to and sort of
Yes, we
explain
do.
what that's about.
Yes, so let's talk about CBTI. I think cognitive behavioral therapy is something that most people have at least heard of, but they might not have heard of CBTI. And it's really just CBT for specifically for insomnia, right?
That's right. And in that type of CBTI, the B part of it, behavioral part of it, is probably the most effective and quickest thing to address in people. And so that's what we usually start off with. And we put the cognitive elements onto it as we go along as sort of icing on the cake. But the substance of the cake is the behavioral therapy. I'll just give you two examples of behavioral therapy. There's one of them that's been around for a very long time called stimulus control therapy. It's a fancy name, don't worry about that. But the instructions about how you deal with it are pretty straightforward and they seem simple, not so simple to carry out, but for the patient. it's more appropriate for people with difficulty getting off to sleep. So sleep onset insomnia. So there are a set of instructions. You can write them out, 5 or 6 set instructions. One is don't go to bed until you're feeling sleepy. So, in other words, don't follow that rule, go to bed at the same time every night. Well, yes, but not when you're fully alert, because you're not going to be able to fall asleep because it's too early in your body clock or whatever. So don't go to bed until you're starting to feel sleepy. So that gives you a little bit higher chance that you will fall asleep more quickly. And then when you do go to bed and turn the lights out, if you are not asleep within a short period of time, like a normal period of time, like within 15 minutes, then don't stay in bed trying to fall asleep, because that vicious cycle will build up and you'll get more and more anxious and angry or frustrated. And those are all emotional responses you don't want to associate with going to bed and trying to fall asleep. They won't work. So get out of bed and go back into another room and do whatever you were doing before. Was watching television? Fine, go back and watch television. Don't be worried about the screen. That's not going to affect you much at all, if at all. Or go back to reading a book or answering your emails, or you can do any of that stuff. But just get out of the bedroom. Stop trying to fall asleep until you start to feel sleepy again. That might take 20, 30 minutes even. So when you do start feeling sleepy again, go back to bed and turn the lights out. But if again you don't fall asleep quickly, again, get out of bed, go back to what you're doing again, and you follow this routine until eventually you fall asleep within 15 minutes. The next thing you know, the alarm clock's gone off and you've woken up. All right, now, in the first few days of carrying this out, you might realize what's going to happen. It's going to take you, it does sound terrible. And just people have to have faith that this works very well if they can follow the instructions. Another very important instruction is you need to pick your wake up time and make that consistent, regardless of how much sleep you got. So if on the first few nights you don't get to sleep until 3 a.m., and you say that I have to get up on most nights of the week at, say, 6 a.m., set your alarm for that. Set 2 alarms so you can't hit the snooze button and go back to sleep again. You need to get up at that time and get out of bed, preferably into the sunshine or into light. And so that's a very important part of the instruction. One other thing, too, is that after following these instructions for 3 or 4 days, it's quite clear that in the first day, you're not going to get as much sleep as normal. Because if it took you a long time to fall asleep on one night, you'll tend to sleep in later to get enough sleep. No, the effect of these instructions is that it'll actually decrease the amount of sleep that you get on those first few nights. And that will build up sleep pressure. And we in fact, are doing this on purpose, and we have to admit that we're doing it on purpose. And then the person will experience greater sleepiness during the day, maybe not on the first day or two, but eventually they'll start experiencing sleepiness. But that's okay for chronic insomniacs who generally are not sleepy to begin with. They will start feeling sleepy for the first time in a long time. And that's, I think, to some extent reassuring for some of these chronic insomniacs. So they'll feel sleepy. And that's almost the only major impact that will have on your daytime functioning. So no, not to worry about it. You'll be able to get through everything during the day, surprisingly so. But so that sleep pressure will build up from not getting as much sleep on that first night and the second night and the third night. But that sleep pressure will build up to the point where the time that you're able to fall asleep after going to bed and feeling sleepy will be quicker and quicker. It'll be earlier and earlier. And so if the next night you get to sleep at 12:30, even though you went to bed at 11 o'clock, and you got out of bed a couple times, but you fell asleep at 12:30 and woke up at 6, you got 5.5 hours of sleep. And then the next night, you might be able to fall asleep at 12.
So, as you're describing all of this, as I sort of jokingly said, but I wasn't joking at all, this sounds terrible. I understand that really what we're doing here is we're teaching our minds and our bodies When it's time to go to bed, we get in bed, we fall asleep. Like we're teaching that behavior. I will admit, I'm one of those people, I would literally stay up and never fall asleep because, like, I don't actually feel tired. So, what do I do?
I think you would eventually fall asleep when your body clock was in the sleep conducive zone. But for you, that would be much later, probably not until 6 or 7 a.m. In the morning. That's why I think the online programs are not going to be as effective because they hear this and they think, oh, okay. And they don't have any personal interaction to encourage them to go ahead and to reassure them that this is not going to be as terrible as it might sound. It will only last for no more than a week before there's really noticeable improvement in how quickly they fall asleep. But it is true that what we're using is a pretty blunt instrument, which is increase of sleep drive and sleep pressure to ensure that the person falls asleep earlier and earlier, night after night. But that's where the cognitive element needs to come into a little bit too, to reassure people that sleep deprivation is not going to damage them, regardless of what they might have heard in the media. Lots and lots of experiments have been carried out, sleep depriving people, and they fully recover and feel fine after they recover with no long-term impairments. Different species have experiences with long periods of sleep deprivation. We have the Australian sea lion who lives off the southern coast of Kangaroo Island in our state of South Australia. And it's a tourist event. You go down, you walk amongst the sea lions, and they're all asleep on the beach. Why are they asleep on the beach all the time? Well, it's because they're catching up on the sleep that they lost when they go out in the ocean to fish. And they're air-breathing mammals, just like us. They wouldn't be any different than us if we tied our hands to our sides and put clippers on our legs. We have very similar brains. And when they're out in the ocean, they dive down to the bottom to do fishing, come back up to take another breath, and down they go again, and so forth. And GPS devices have been put on them, so we know precisely what they do. And they do not take long sleeps in the 2 or 3 days that they're out in the ocean. So they are basically sleep depriving themselves every time they go out for a fish by 2 or 3 days. And then they have a full tummy and they come back to the beach and they crash and sleep 20 hours, the first 24 hours, then 15 hours, and then 12 hours. And then by that stage, they've caught up on their sleep, but now they're hungry again. So out they go into the ocean. So they live this schizophrenic life between the ocean, where they are feeding and not sleeping, and back to the beach, where they're sleeping but not feeding. So they're satisfying two basic biological drives. And this does not seem to hurt them at all. It's a bit like university students who have a big assignment every week and they stay awake for 2 or 3 nights in a row, finishing their assignment, and they crash after that. So you would think, gee, that's terribly unhealthy to do that. But that's what the sea lions are doing throughout their whole life, and it doesn't seem to impair them. So there's no evidence that the loss of sleep, as long as you can make it up and recover, is dangerous to you. The thing that would be dangerous to us humans is if we got into a car and drove in a very sleep deprived state and likely to crash and hurt ourselves or kill ourselves. That's the biggest threat. But it isn't from a biological deficit that is produced by this. So we have to reassure these people that the loss of sleep is only going to make them more sleepy. And if you're starting with insomniacs that have a very slow sleepiness to begin with, then they have room to improve before they get into that excessive daytime sleepiness area. But of course, if they are really sleepy, they shouldn't be driving. But most of them don't ever get to that point during the day. They start getting sleepy at maybe 10 or 11 o'clock at night, which is the time that they need to be asleep. So this type of therapy is a behavioral therapy. It needs to be complemented with some cognitive therapy to reassure people that this is not going to hurt them. It's only going to make them feel sleepy. It is going to help them retrain their bodies so that going to bed and turning the lights out is now associated with a rapid sleep onset rather than anxiety response. And so they get more and more confident that this is working and their anxiety levels come down and that automatically triggered off arousal response gets extinguished. It fades away. That is a behavioral therapy that has been around since 1970s. We know it works, and there's just a huge amount of evidence that it works if people can comply. They just need to be reassured that the compliance is not going to hurt them. And a week investment, an investment of a week or 2 weeks of time doing this will have more or less a permanent beneficial effect on their ability to get to sleep.
Yeah. And I would say too that yes, there's pain in doing this, but also there's a pain in not doing it.
Well, there's a long-term pain.
Yeah.
I try to reassure my patients that having insomnia is not going to have any significant detrimental effects on their overall health, but it certainly does affect quality of their life. I mean, you feel rotten, you feel fatigued, you feel distressed, and you're somewhat angry and frustrated that you've had this so long. You've tried everything. You've tried all the sleep hygiene rules. None of them work. You've tried all of the herbal remedies at the health food shops. They might work for 1 or 2 nights and they stop working. That's a placebo effect that's finally worn off. And so their life is lots of time pretty miserable. That's not nice. And that's enough reason to treat the insomnia so that you have a better quality of life, basically, and you feel more energetic and your life will probably become more productive. You'll become a nicer person to everybody else and you'll be liked more. And so, your life becomes a little bit rosier and less negative if your insomnia is treated. And that is by far enough reason to get it treated and to invest a couple of weeks of effort in correcting this problem. And it can be corrected. It's really very straightforward. But it does. Indeed, I appreciate what the effort is that the people and the changing people's behavior is not easy. Getting them out of a rut and out of a habit pattern to change it into a new habit pattern takes a lot of attention and concentration and reinforcement when they do it well. Pats on the back on the head and you're doing really well. So a lot
That's
of
right.
positive reinforcement, a lot of trying to reassure them that it's not going to hurt them and it's going to be an investment of effort in the long term, which will really be a benefit for them, basically permanent. Now, you can't guarantee that it'll be a permanent change. And it may be the case that in a year or two's time, they will experience some stress in their life or trauma, and the insomnia comes back again. But they'll know what to do. They can carry it out themselves. And they can feel confident if they do that for just a week, they'll be back on track again. So they'll have the power within themselves to be able to treat the insomnia. But I want to get around to the other behavioral treatment, which is probably a more commonly used one. It's been called several different names. Some names I don't like, and we've changed the names because they seem negative. Sleep restriction therapy is the original term. And you tell this, well, we're gonna use sleep restriction therapy on you. I said, oh no, I already don't get enough sleep. You're going to restrict my sleep even further. Well, yes, but to call it that is unnecessarily alarming, I think. Better terms might be sleep efficiency training or bedtime window is another one. And that sounds nice. Regardless of the name, I'll tell you what's involved in it. That type of behavioral treatment, the one I'm going to talk about, is more appropriate for people who have awakenings across the night, as well as difficulty getting to sleep. So if they have a combination of symptoms, like it takes them a half an hour to get to sleep on the average, and they're awake for at least an hour and a half across the night, and sometimes they wake up too early too. So they're overall getting too little sleep with lots of awakenings and difficulty getting to sleep and getting back to sleep. That type of insomnia is best treated by this bedtime window or sleep efficiency training. And quite often we find that these people are spending a lot of time in bed, but not very much time in bed sleeping. So we have a measure called sleep efficiency, which is the percentage of time that you're in bed actually asleep. So if you're in bed for 10 hours and you feel like you're only sleeping 5 hours, you have a sleep efficiency of 50%. And that's well below normal. And you're spending 5 hours of time in bed awake. And that time in bed awake is usually counterproductive. It's strengthening that automatic conditioned arousal response. So you may guess, what do we suggest for this treatment? They're going to bed maybe at 10 o'clock at night because they think they need to have a regular bedtime, even though they're not feeling sleepy then. And they're getting out of bed at 8 o'clock in the morning. to give themselves plenty of opportunity to get enough sleep. So they're going for getting as much sleep as possible. And to do that, they spend a lot of time in bed, much more time in bed than they are asleep. So that type of example is perfectly suited to this bedtime window or sleep efficiency training. And what this entails is, let's say my hands are representing bedtime wake up time, 10 o'clock and 8 o'clock, 10 hours of time in bed, and they're reporting only 5 hours of sleep. Well, they might be underreporting their total amount of sleep, and we can talk about that sometime later. So maybe objectively they're getting more like 6 hours of total sleep time. We suggest to them, we want to have a bedtime window of only 6 hours of time in bed. And that might freak them out to begin with. Like, God, I'm only going to get 3 hours of sleep.
If it takes me 10 hours to get 6 hours, and now you're only giving me 6 hours, that means I'm only going to get 3. Like, that's the thought.
That's the thought. Absolutely. And they need to be reassured that, no, that won't happen. They'll get a higher percentage of sleep in that time in bed, but they won't get as much sleep as they are presently getting. So again, a fairly heavy duty sledgehammer of sleep restriction is the method of operation. So the bedtime window down to 6 hours. And we leave it up to them as to what 6 hours of time in bed is going to most suit them. They might say, oh, my partner goes to bed at 10. They want me to come to bed with them. So, okay, go to bed 10 and get out of bed at 4 a.m. Oh, no, that's too early. So, there's a bit of toing and froing and
negotiating
consensus as to what time do they want to go to bed and get out of bed.
Yeah.
This is going to be held strictly for the first week at least. So a full week. And so if you get their agreement with this, and it's good to tell the bed partner as well, if the bed partner comes along, to get them in on it so they know what's going to be happening. They know that their bed partner's not going to come to bed 2 hours later. That might not bother them at all. But the bed partner getting out earlier than they get up might have to make some sort of practical arrangement for at least a week. So they hold their time in bed to 6 hours. In the first night, they only get 4 hours of sleep, which is a couple hours less than they normally get. And so they feel a little bit sleepy the next day, but not so bad. But the next night, again, they might get 4.5 hours sleep because they built up a bit of sleep pressure at getting less sleep than they normally get, and so on throughout the week. And gradually, their sleep time tends to start filling out that 6 hours of time in bed. We have squashed their bedtime down initially. They get less sleep than they normally do. Sleep pressure, again, builds up night after night. And the sleep pressure that they have from the first night gets carried across that day and into the next night. And so people have this phrase, oh, I lost 3 hours of sleep last night. That's not the best way to look at it. You don't lose it. It doesn't disappear entirely. It builds up sleep pressure. And you're saving up that sleep pressure. So if you think of the sleep piggy bank, you put 3 hours of lost sleep into your piggy bank. You saved it up for following nights. That's a better way of thinking it, a more positive way. And it's truer to the fact. And so gradually over that week, sleep starts filling out that 6 hours much more. And so the sleep efficiency, that is the percentage of time in bed that you're actually asleep, increases and increases. And we want to get it up to about 85 or 90% figure. It may not reach that by the end of the first week. It might only get to 75% or 80%. But it's starting to work. And people are saying they're falling asleep more quickly. And when they do wake up at night, they're falling back to sleep more quickly. So that's great. So they're getting an experience of less time awake in bed and falling asleep more quickly and falling back to sleep more quickly. And you ask them, well, how are you feeling during the day? After that first week. Oh, okay. I'm coping with this much better than I thought I would. But their sleep efficiency still at maybe 80%. It's not as high as we want it to go. And so we say, can you do this another week? And they think, okay, all right, I'll do it another week. And they stick to it. And at the end of the second week, almost always, their sleep efficiency is well above 85%. And they are starting to get really sleepy in the evening before their assigned bedtime. If their assigned bedtime, let's say it's midnight and they're sleeping and they're getting out of it at 6 a.m. in the morning, they're struggling to stay awake before midnight. And now that struggle is not seen as too aversive to them because this is a new experience for them. They've
Right.
never
To
felt sleep
actually
at
be
night.
tired at bedtime?
Well, tired, sleepy.
Sleepy.
And
Yes.
so they are drifting off to sleep. Again, that's where your bed partner and members of the family can be helpful. Wake up, John, you've fallen asleep. Because it's not good to fall asleep before going to bed and get a power nap, which is going to alert you a bit more and take longer to fall asleep than when you do go to bed. So it's better to do something maybe physically active. So you can break all the sleep hygiene rules during this therapy, which is sort of a relief in a sense. Like I hated those sleep hygiene rules. I can't work on my computer and answer my emails. Get on your computer, answer your emails, do whatever it takes to keep you awake until your bedtime. Because the struggle now is to stay awake until your bedtime. And then at bedtime, you're falling asleep 10 or 15 minutes every time. So clearly it's not interfering with your ability to get to sleep because you've got that good sleep pressure working for you. But also because you're reconditioning your system now so that bedtime and the attempt to fall asleep is now followed by rapid sleep on every time. And so after 2 weeks, they've been really good at sticking to the 6 hours of time in bed. This is just an example. Some people it might be 5 hours, and other people might be 6.5 or 7 hours, depending on what their initial pattern looked like. At the end of that second week, their sleep efficiency is up to 90%. That's above the threshold now. And now we can extend their time in bed, but gradually by half an hour in half-hour steps. So we extended to 6.5 hours. And I love to see them come in at the end of the second week. And I say, you've done really well. And they know they've done well. And they know that they're going to get an extra half hour of bedtime. And so that's a real reinforcement to them.
Yeah.
And they
Yeah.
can go to bed a half an hour earlier, or they can stay in bed a half an hour later, but sticking pretty much to that same schedule. So they might say, oh, I'm struggling so much to stay awake. Can I go to bed at 11:30? Yes, 11:30, but out of bed at 6. And so they have 6.5 hours time in bed. And they hold that for a week, and then they're reassessed at the end of that week. If their sleep efficiency is still above 85%, they can get an extra half hour time in bed, 7 hours of time. And usually we find that when we extend it out to about 7 hours of time in bed or 7.5 hours time in bed, that gets to the point where they're no longer feeling sleepy during the day and they're feeling great during the day. Their fatigue levels have dropped off to normal levels. They're feeling much more energetic and they're feeling good. They're feeling less distress. And they said it was really a simple idea. Why didn't I do this much earlier on? When they go through that process of 2 or 3 weeks of paying attention to their sleep pattern, they get really basically a permanent improvement in their sleep. And then they also know that if in the future, if they allow themselves more time in bed, let's say, oh, I'll just relax and spend 8.5 hours time in bed. And on the first night, they might get 8 hours of sleep and feel really rested the next day. That's fine. But the next night, they try 8.5 hours and then they get 7 hours of sleep. Oh, spend a lot of time getting to sleep and a lot of time awake during the night. Yeah, okay. So they paid off their sleep debt and they're getting more of the time in bed than they need to sleep. And so they're getting more wake time. If that goes on for too long, gradually the insomnia can work its way back in because they're lying there awake in bed, they're thinking
Right.
and
You're
getting frustrated.
retraining yourself to not sleep when you get
That's
in
right.
bed.
That's
Yeah.
right. So, but they know, oh, okay,
I know
I'll
what
do
to
what
do with
Dr. Lack
this.
suggested to begin with. I'll collapse it down to maybe 7 hours of time in bed.
Yeah.
And it might take them a couple of weeks to, get back to a good sleep efficiency level then again.
Yes, yes. I love this. I love this. I want to talk to you listening for just a quick second because with fibromyalgia, I know for me, if I don't get good sleep, like that is the thing that will increase my pain. And so I just want you to think for a minute. Yes, you might have more pain while you're going through this. You might have more fatigue, more brain fog, more all the things, right? But if you can get through this and you have better sleep, that will make your pain better. That will give you more energy. That will reduce your brain fog. So it's a means to an end. It's not a method of depriving you of sleep for the rest of your life. It's a method of hopefully giving you more sleep.
And a really good research idea here. I suspect that during this process, this CBTI, they won't actually have an increased experience of pain. you're right in the sense that getting a good sleep tends to make you more resistant to pain and cope with it more easily. I think there's good evidence for that. But the element of sleep, which seems to be most related to that decrease of pain sensation, is deeper sleep.
Yes. Yep.
And during this cognitive behavior therapy, while you're increasing sleep pressure, when you do sleep, you get into more deep sleep. In fact, so I think that will inoculate you against that pain to some extent. You'll feel sleepier, but not so much fatigue and pain. That's my suspicion, but I don't know if there's any evidence.
Yeah, that could very well be true. I was talking with you, before we started recording about the fact that tomorrow night is daylight savings here in the US as we're recording this. And so for the past week, I've been trying to move my body clock a little bit by little bit so it's not so painful when the clocks move forward. And I will say that it hasn't been as bad as I thought that it would be. And I have, in being a lot more aware and a lot more consistent about having to get up every morning, because I keep telling myself if I don't, I will really hate it next week. I have noticed actually more deep sleep, being more consistent, paying more attention, like whether I like it or not, getting up at the same time anyway. We don't like to hear these things because they don't sound fun, but they really are the truth.
Yeah, it's just a matter of sticking to it and persevering a little bit. So the morning bright light, set your alarm to wake up at a certain time and really try to stick to it. And as soon as you're awake, get some light. I don't know if we ever talked about melatonin in the last one.
Just very briefly mentioned it as potentially a tool for helping to change
Change the timing of your
change the
body
time.
clock.
Yeah, but we didn't
Yeah.
go into any details.
Yeah, melatonin doesn't have very strong evidence as a good hypnotic, but we do have a lot of evidence that it can help to retime your body clock. And for going on to daylight savings time, you need to shift your body clock back a little bit earlier. And so if you can get yourself some melatonin, and I understand in the United States, you can get it over the counter. Now, the purity of it may be a little bit variable, but that doesn't matter for this purpose. Get yourself a low dose melatonin, like 1 milligram. If you can only get 3 milligrams, break it in half and you have 1.5 milligrams. That'll work fine. And quick release melatonin. Don't get the sustained release. So for the retiming of the body clock, you want a low dose, quick release melatonin. And when do you take it to advance or to shift your body clock earlier? About mealtime. So take it with your evening meal. It's around 6 or 7 p.m. in the evening, or even a little bit earlier. But mealtime is a good time to remember it because you're consuming other things too. And take that for 3 or 4 days before going on a daylight savings time. And that'll help shift your body clock maybe 10 or 15 minutes a little bit earlier each time you take the melatonin, so that your body clock, along with the morning light and the melatonin, they act in concert with each other. They don't eliminate the effects. So they work in synergy with each other.
That's right. That's right. And so then when the clock goes the other way,
Most people have very little problem with that.
that is true. It just means we get to sleep in an extra hour.
Yeah, you're allowed to sleep in an extra hour, but then you need to hold it at that time.
Yeah. Yeah, that's right. That's right. So the last question I want to ask you, because I mean, we could talk for hours, but it is Friday evening, my time as we record. The last question I want to ask you is about access to CBTI. We talked about the fact that there aren't a lot of practitioners out there, even though direct, in-person, individualized support is always going to be better. Would the online, the apps, the more virtual therapies, are they better than nothing? Or do we do it ourselves? What are your thoughts?
If your audience is convinced enough that if they did follow these instructions, if they can do it themselves, it will work. It's just that it's helpful for most people. We're social animals, and having somebody paying attention to what you're doing and giving you feedback and reinforcement when you do it appropriately certainly helps most people adhere to the instructions, which are superficially sound pretty horrendous, but are not actually. Look at a list I can send you. A friend of mine at University of Pittsburgh has compiled a list of CBTI practitioners in North America mainly. I can send you that list. You can make it available to people that want to
That would be
inquire.
awesome.
I
Yes,
think
that
he
would be great.
has several hundred on that list, so you might be able to find somebody. Sure, there are maybe half a dozen people in the Seattle area, for example, that do CBTI, and in most urban areas, there'll be a few people. Now, they might be fully booked, but
That's a different question, right?
at least they might know somebody else, who can help out as well. Because the number of people that can do this is increasing steadily. Tammy, I'll send that list to you early next week, and you can have it available.
That'll be perfect. And so if you guys want to grab a copy of that, just go to today's show notes, fibromyalgiapodcast.com/182 for today's episode. We'll have that where you can download it. And, if it's just a matter of really accountability, somebody to help troubleshoot with you, that is a lot of what we do as coaches, just to be that friend to come alongside you and say, okay, how'd you do this week? What time did you go to bed? When I was working really hard on my sleep way back at the beginning, I had a friend who was sort of being my coach at the time. And she had me text her every night when I was going to bed. And if she didn't hear from me, I would get a text from her. Are you going to bed? Not all of us are as internally accountable. Sometimes we need that external accountability.
Yeah. Look, I think the analogy with going to the gym and having a personal coach at the gym is very similar to this. I often feel like a sleep coach when I am, quote, treating people with cognitive behavior therapy. It really is helpful to have that one-on-one encouraging environment for people. And if they do have it and they appreciate it, they will adhere and it'll work.
Well, there you go, folks. Thank you so much for being here. This has been a thrill like last time. It's been such a pleasure. We definitely will have you come back. We were talking before we started recording about a lot of the myths and anxiety and all the other things out there surrounding sleep. So we'll have to plan to have you come back for another episode.
I'd love to. This is a bit of a hobby horse of mine now, but trying to dispel a lot of the myths about sleep, which I think are not helpful, particularly for people who have chronic insomnia already, or are starting to get worried about their sleep and are potential chronic insomniacs. So in the zeitgeist of preventative medicine, I think this is a message we have to get across to sort of rectify and get some perspective on sleep and its relationship to us.
Absolutely. Absolutely. I agree with that because, sometimes that is the straw that breaks the camel's back, right? It's the thing that triggers that anxiety that sets the whole thing off. So thank you again so much for being here. And for you listening, hang on. We'll have this week's listener shout out and a few more resources for you.
Lovely talking to you, Tammy.
And that wraps up my conversation with Professor Leon Lack from Flinders University and the Adelaide Institute for Sleep Health. As I mentioned at the beginning, we have several other episodes about sleep that we've linked in today's show notes. To access those, just go to fibromyalgiapodcast.com/182. And now it's time for this week's listener shout out. This one comes from Robin in California about certified fibromyalgia coach Ann Garner, who I interviewed in our last episode. Robin says, Ann is a tireless advocate and a skilled coach for fibro moms and their families. If you are a mother with fibromyalgia and or you have a child with chronic illness, you will want to have Ann on your team. Thanks so much for that, Robin. And I would love to hear from you, too. If you've had an experience working with one of our coaches, if this podcast has helped, or if you've been reading articles on the Fibro Compass, our digital magazine and blog, I would love to know. You can send me a message through our website at fibromyalgiapodcast.com or leave a quick review wherever you listen to podcasts. Those reviews really help other people with fibromyalgia discover the show, and I read every single one. Who knows? maybe you can be our next listener shout out. Take good care of yourself, and I will see you back here next time. And that wraps up another episode of the Fibromyalgia Podcast. I'm your coach, Tammy Stackelhaus. For daily doses of hope, inspiration, and practical advice, come hang out with me on Facebook. Visit facebook.com/fibrocoach to find my personal coaching page and connect with me directly. To find the show notes, additional resources, or to schedule a consultation with me or one of my coaches, visit fibromyalgiapodcast.com.